So now, to address these questions, what are the ways we can go about evaluating these patients? As I mentioned to you, shunt fraction evaluation is the key to deciding on the way you are going to follow these patients. There are two ways you can estimate this shunt fraction. What we use routinely is this 100% oxygen method. I will come to it shortly. And once you have defined that there is a right to left shunt and there is a shunt fraction is beyond 5%, then you need to have imaging evaluation to decide on the course of treatment. There are many investigations which you can do. We'll go over them quickly. Now, just a brief word about shunt fraction evaluation. There are two ways you can do it. You can do it by giving 100% oxygen, or you can use radionuclide studies to do that. Radionuclide studies are actually slightly better than this 100% oxygen method, but they are far more expensive and far less widely available, so therefore they are not routinely used. Essentially what we do here is we give 100% oxygen and we measure the oxygen saturation and arterial oxygen after a period of time. A shunt fraction of more than 5% is considered abnormal, and this is abnormal in majority of the patients with pulmonary arteriovenous malformation. So now, the easiest way to diagnose the presence of a pulmonary arteriovenous malformation is to do a contrast echocardiography. What this basically means is we inject agitated saline in a peripheral vein, like for example in the arm. Normally what happens, the saline will travel into the right atrium. You will see some agitated, some echoes within the right atrium, and they will dissipate as this gets absorbed into the pulmonary circulation. In patients with intracardiac left to right shunts, what happens? Immediately within one cardiac cycle, you will see this contrast agitated saline in the right atrium and then in the left atrium. In presence of pulmonary arteriovenous malformations, it takes 3 to 8 cardiac cycles before this contrast appears in the left atrium. So this is the best and the easiest way to diagnose pulmonary arteriovenous malformation. Depending upon which pulmonary vein is showing this contrast, you can actually identify the location of malformation as well on contrast echocardiography. Now, once the diagnosis of pulmonary arteriovenous malformation is established, you need to decide how you are going to treat it. To do that, you need to have image of this malformation. At this time, the investigation of choice for this evaluation is CT angiography. With the advent of this race for different slices or rising slice race, CT angiography has emerged as the standard of care for the evaluation of pulmonary arteriovenous malformations. Why? Because it can show the vascular anatomy very well. It can show it in sequence as it moves forward from the pulmonary circulation to systemic circulation. It has tremendous three-dimensional capabilities, and because of which you can identify the vessel, you can measure the vessel, choose the device which you want to use, so therefore it helps in treatment planning. This is one pertinent example here. This is the serpiginous mass in the chest radiograph, which is typical of a pulmonary arteriovenous malformation. You see the pulmonary venous connection. You see the systemic arterial supply to this pulmonary venous connection. So effectively, you can identify the lesion, you can understand the image morphology, you can decide on your treatment plan which catheter you want to take, where you want to lodge it, what size coil or a plug you want to use. All these things you can decide based on the evaluation of a CT angiogram. MR angiography or MR imaging can also do the same thing actually. See what happens, in majority of the lung lesions you will find relatively long relaxation times and relatively medium to high signals. Typically in a spin echo sequence, a rapidly moving blood will show a flow void and low intensity signals, and on a gradient echo signals it will produce a bright image. Like for example here, you can see the malformation the same way as you would see in CT. You can measure the feeding artery in the same way and decide whether there is a landing zone for the device landing, what size device should I use. All these issues can be decided based on the evaluation of an optimal MR angiographic image as well. Is MR angiography takes a much longer time, and most of us, the intervention radiologists, have much shorter patience in terms of doing these procedures. So CT angiography is a much faster technique. But jokes apart, the truth is that it is far more patient compliant in terms of discomfort, in terms of period of examination. This is the reason primarily why CT angiography is rapidly replacing all other techniques for the evaluation of these patients. But as you can see here, this is a patient who had an MR angiogram with showing the arteriovenous malformation, showing the feeding artery and the draining vein. The catheter angiogram in the same location, and you can see standalone MR angiography can actually answer all the questions which you need to ask before treatment planning. Having said this, catheter angiography remains the standard of care for the evaluation of pulmonary arteriovenous malformations and is justified in all cases where further treatment is planned. You must do selective injections into both the pulmonary artery and preferably into each lobar artery to clearly identify the arterial anatomy before setting out to embolize them. Also, this is the only technique which gives us a clear estimate of pulmonary arterial pressures, which are essential for treatment planning. So therefore, pulmonary artery angiography has a clear case in the diagnostic evaluation of a patient with pulmonary arteriovenous malformation. So now, how should I summarize this? What is our strategy? This strategy which we have developed over the last 30 years is a patient who comes to us with a clinical suspicion or an abnormal chest radiograph suggestive of pulmonary arteriovenous malformation undergoes a contrast echocardiography to establish the diagnosis of pulmonary arteriovenous malformation. Once this is established, we do a shunt fraction. It's a non-invasive technique, and define the degree of shunting which is happening. If the patient is symptomatic, or if the patient is asymptomatic with a specific size of this malformation, we proceed and do a CT angiography. At this time we stop. Only if the patient is to be treated by endovascular or surgical means for these malformations do we move a step forward and do a catheter angiography. Catheter angiography is done as a single sitting procedure and is extended to an endovascular procedure in this setting. So with this understanding, what should be the optimal approach to the management of pulmonary arteriovenous malformations? Now, you must understand that at this time there is no consensus opinion in literature on how every patient with pulmonary arteriovenous malformation should be treated. The problem is, one, these are very rare disorders, so the total number of patients you would see in a given lifetime is not very big. The second problem is, because of this reason, the natural history of this disease is very poorly understood. Because of these two factors, the consensus opinion is not available. However, we do know that malformations which are more than 3 centimeters in size have over 50% morbidity in untreated patients, vis-a-vis 3% morbidity in patients who receive treatment. So clearly there is an understanding here, malformations which are beyond 3 centimeters in size should be treated irrespective of their symptom status. So 1 in 4 malformations will increase over time. So gradual progression of the size of malformation or a rapid progression of the size of malformation is a standalone indication for treatment. Also, association with hereditary hemorrhagic telangiectasia is a sign of poor prognosis, so may be a sign for early intervention.